All right, we're going to move on to case number 2. So this has to do with a gentleman, Kumar. He's 70, male, and has persistent shortness of breath and frequent COPD exacerbations. So we're going to go over his case and medical history and think about his treatment plan a little bit in this case. So 70-year-old gentleman, multiple exacerbations, requiring antibiotics and steroids, and that's despite being on inhaled triple therapy, no history of asthma, but does have some family history of allergic rhinitis and eczema, some nighttime cough, intermittent wheezing, 30-pack-year history, but quit 15 years ago, has some dyslipidemia and GERD, but no hospitalizations in the last 12 months, just the 2 urgent care visits and no known drug allergies. So this is just some data on the frequency of COPD exacerbations comparing 0, 1, 2, and 3 to triple versus the 2 versions of the dual. So that's LABA-ICS and LABA-LAMA. And generally speaking, you can see that there are more patients with 0 or 1 and more patients with 2 or 3, depending on the treatment regimen, with the more intense triple therapy regimen having kind of the weight of fewer exacerbations. We also know that COPD exacerbations themselves are associated with increased mortality. This just shows patients in the orange line who've had no exacerbations, in blue 1 or 2, and in green 3 or more. Again, just the more frequent, the more likely patients are to die. We know hospitalized events in particular are also associated with high mortality. So kind of keeping this in the back of our mind, we probably want to try to treat Kumar more aggressively. The 4 events in the last year is not really ideal. He lives with his spouse in a suburban area, former construction worker, retired 5 years ago, 35-pack-year smoking history, quit 3 years ago, occasionally drinks alcohol, history of COPD and hypertension, GERD and osteoarthritis, appendectomy at 21 and hernia repair at age 60. So this is just a little bit more about what to do if you were to happen to see Kumar during an acute exacerbation. I will say a lot of times I don't actually get to see my patients during these acute events. They happen locally, primary care, urgent care, as in the case of Kumar. They often don't end up in my office, but they end up in your office. Things to think about, obviously, vital signs, oxygen saturation, assess for confusion or impaired consciousness, examining the chest, check ability to cope at home, and then think about whether you need to send the patient to the hospital. We don't routinely send cultures right away. And then obviously the differential, could it be heart failure, PE, or pneumonia? So for this particular event, patient had increased use of accessory muscles, a little bit of confusion, which obviously is concerning, increased heart rate, and a borderline oxygen saturation of 90% on room air. I know that these are not easy to get, but in our dream case world here, we have the ABG, which does show an elevated PCO2 of 55, which I think is probably the most concerning thing on here. White count is 10.1, blood eosinophil count 420, which is elevated, as is the CRP. I will say we don't often get pulmonary function testing in the middle of an event, but in this case we have it, and he has significant lung function impairment with an FD1 of 43% predicted. Chest X-ray is pretty clear, doesn't show any evidence of pneumonia. Just to kind of remind ourselves, increased blood eosinophil count associated with type 2 inflammation, actually less likely to be associated with bacteria and pneumonia. The good news is does respond well to inhaled steroids, as well as some of the type 2 targeting biologics that were approved for COPD this last year. In terms of proportions of COPD patients who have more exacerbations, we tend to see patients at the higher end of the eosinophil count. So we know higher eosinophils tend to be associated with higher exacerbation frequency. There are likely several endotypes within COPD, and we're just trying to understand how to tease them out. We are fortunate in that with type 2 inflammation, we have a reasonably good biomarker, which is the blood eosinophil count. For some of the others, it's a little bit more challenging. For instance, patients with persistent pathogenic bacterial colonization, or maybe kind of a neutrophilic phenotype, But another endotype that I think everyone's probably really familiar with that has a very targeted and specific therapy is alpha-1 antitrypsin deficiency. But I'm hopeful that as time progresses, we'll better understand how to additionally identify these other endotypes and have other specific therapies. This is I realize, an extremely complicated diagram just showing some of the cells as well as cytokines involved in type 1 and type 2 inflammatory pathways. Interestingly, some of the same things can set these cascades off, whether it's air pollution, smoke, viruses, bacteria. But just depending on the unique situation, it may trigger one or more pathways. But important to the type 2 inflammation pathway, we see eosinophils. Other key cytokines include IL-4, IL-13, and IL-5. On the other side of things, for type 1 inflammation, type 1 cells, dendritic cells, neutrophils. And there are other, in addition to the dupilumab and mepolizumab, there are other pathways being studied in COPD, and that includes active clinical trials looking at drugs that target both TSLP as well as IL-33. So going back to GOLD, I touched on this earlier, but when we're thinking about dyspnea management, you want to maximize bronchodilator, consider adding ensifentrine. For exacerbations, we want to maximize inhaled therapy, including inhaled corticosteroids, and then consider one of these add-ons, whether roflumilast, azithromycin, or dupilumab. In general, we know that dual bronchodilation is more effective than mono in terms of improving lung function, symptoms, exercise capacity, as well as reduction in exacerbations. And that's why GOLD moved a few years ago to having patients initiate with dual as opposed to single bronchodilator therapy. Triple bronchodilator therapy, in particular, I think about that for reducing exacerbations. That's where that inhaled steroid component really shines. And we think about this for patients having frequent exacerbations or persistent symptoms, in particular those with eosinophil counts of 100 or more, and who remain symptomatic, remain having events despite dual bronchodilator therapy. Occasionally, one of the things that the GOLD has introduced in the last few years is thinking more carefully about when to initiate ICS as well as actually when to withdraw ICS. But strong support for use is those with frequent exacerbations, hospitalized exacerbations. The higher the eosinophil count, the more likely patients are to respond. On the other end of things, if the patient has repeated pneumonia events or very low eosinophils, or in some cases mycobacterial infection, you may want to think twice about inhaled corticosteroids for that patient. This just goes over some of the clinical trials that have helped us get to where we're at with respect to some of the drugs that are currently on the market. So if we start at the bottom with the METRICS and METREO studies, these were the earliest studies that were done of mepolizumab. They did not have the strict eosinophil enrollment threshold that MATINEE ultimately had, but ultimately the combination of those three studies led to approval for mepolizumab. For dupilumab, we have the BOREAS and NOTUS studies that you can see in red. Unfortunately, another IL-5 targeting pathway drug, benralizumab, that is FDA approved for treatment in asthma, actually did not make it through. So Terra Nova and Galathea were negative, and unfortunately the Resolute study just read out and it is also negative. I think we're all going to need to see a little bit more data to understand why that, whether it was the study design, et cetera, that impacted that study being negative. Okay. This just gives you a little bit more, a little bit of a deeper dive into the mepolizumab studies that I mentioned. So there was the METRICS and METREO studies that were sort of the first studies. And as you can see, the METREO study looks positive, whereas METRICS didn't. And that's why ultimately, if you can look at the eosinophil count breakdown at the top of the slide, this is ultimately what led them to do the study that kind of got them across the finish line, which was the MATINEE study, focusing on patients with an eosinophil count of 300 or more. This is like a little bit deeper dive on Boreas and Notice. This is phase 3 pooled analysis, and again, just showing robust data regarding exacerbation reduction. They also happen to show FEV1 improvement as well as symptom improvement. A little bit deeper dive on some of the, just comparing some of the outcomes for dupilumab and mepolizumab. Both both showed good improvement in exacerbations, although the symptom and lung function improvements were a bit more robust for Boreas and Notice as compared to Matinee. So when we think, I mentioned this earlier, but this review cycle is really important. It was added to the GOLD document a few years ago. But when you have patients come into the office, you want to assess for symptoms, assess for exacerbations, and then look at if you're still struggling, you want to, before switching medications, you want to ensure adherence, make sure their inhaler technique is correct, think about non-pharmacologic approaches, and then if those fail, consider escalation, switching device or molecules, or both. So for this particular patient, going back to Kumar, he had 4 exacerbations last year on triple therapy, elevated eosinophil counts. He's really a perfect candidate for dupilumab in this particular instance. In addition to that, addressing adherence barriers, enrolling in pulmonary rehab, optimizing management of comorbidities will all kind of be an important piece of his treatment plan. So just to summarize, recurrent exacerbations despite triple therapy should really warrant reevaluation of the patient and what they're taking, how they're taking it, and whether they need escalated therapy. GOLD 2025 includes biologic options for type 2 inflammation. I anticipate this will be expanded with GOLD 2026 out in November. Biomarkers such as blood eosinophils can help to guide therapy, but I think the clinical context is really essential. And treatment plans increasingly need to be individualized for the patient and incorporate the disease severity as well as comorbidities. And of course, we always need to think about non-pharmacologic strategies, including pulmonary rehabilitation. So with that, I'm going to turn it back over to Dr. Bose.
So we're actually about time to now wrap up our session. So I'm going to take some few minutes to go over the key takeaways here. So I hope we've really highlighted the personalized nature of management, some of the strategies that we're using now in 2025 to manage patients with COPD. These include symptom burden, exacerbation history, and also the incorporation of biomarkers for blood eosinophil count that are all new in the last several years. We used to be, unfortunately, sort of stuck at the triple inhaler point. So 3 drugs through the inhaler don't need to be the final step in 2025. And so really trying to better understand how we can target and tailor our therapies to the type of inflammation that we're dealing with is really important. The newer therapies that Dr. Han and I spoke about, including ensifentrine and dupilumab, and also, of course, stay tuned for others coming into GOLD 2026, are now integrated in what we have and really get us to a point where we can offer additional options, particularly for patients who have type 2 high disease or refractory dyspnea. The non-pharmacologic strategies are still in our armamentarium. We should not forget about them. Pulmonary rehab, as Dr. Han showed you some evidence, is really quite underutilized, but can be very useful. Inhaler technique training is essential, and really making sure we take a holistic view of the patient and treating the comorbid conditions that might be confounding our picture and also increasing morbidity. And really, I think there's a great appreciation for the fact that we're really desperate to find these biomarkers so that we can really provide a personalized therapy plan. And so in 2025, we've got eosinophil counts as the key biomarker that we've been looking at to be able to base our understanding of who is going to respond to ICS or other biologics, but also need to be thought of within the context of the whole patient rather than just treating that number. I'd like to encourage everybody to click continue after this is over to complete the brief post-test and your evaluation for this course. After you submit the post-test and achieve an 80% accuracy, you will be emailed a certificate for your AMA or ANCC certification and credit. And this credit will be submitted to Rush University and posted to the CPE monitor. You can also join us at www.practicepointcme.com to see other presentations of interest beyond COPD and receive additional accreditation and credit for those courses. We also have a mobile app that you can download onto your device. Scanning the QR code shown below will help you to avail a lot of these options on the mobile app. And with that, I'd like to thank you for your attention and your participation to this course that Dr. Han and I have had the privilege of doing with you. And hopefully it was a valuable session and will help influence your care of COPD patients. Thank you, everybody.
Thank you.